This is Dr. James Eady of Retina Associates and Retina Vitreous Associates of Southern Chicagoland and Northwest Indiana. Today I'm going to show a case of a refixation of a dislocated posterior chamber intraocular lens. The dislocated lens is a 3-piece IOL, and my preferred procedure for these is to refixate them to the sclera using a modified Yamane procedure. I did do this case under general, and typically I save the block to the end, but in this particular case the patient was having some tachycardia, and anesthesia asked that I do a block to hopefully tamp this down a bit. My reticence to do a block preoperatively is tied to the fact that I don't like the conjunctiva to bubble up. I don't have a corneal marker in my OR, and I tend to make the preoperative markings using the caliper. There is a little bit of eyeballing the exact horizontal markings, and I'll oftentimes check it with an instrument that you'll see soon. I'm a little bit off with my initial markings, and I think perhaps sometimes I spend a little bit too much time trying to get these geometrically perfect. Based on where the sclerotomies end up sitting, they're rarely exactly where you make the marks. As you can see, instead of being completely vertical, I've skewed this a bit on the diagonal, and this is because of the patient's nose. This is a right eye, and the patient had a large nose, which makes the inferior trocar placement difficult and grasping difficult, which we'll see later in the case. I like to place the sclerotomies for the haptics 2.5 millimeters posterior to the limbus. You can see superiorly I'm a little bit off with my initial marking and do a bit of adjusting. The irony of checking my geometry with a bent Kugelin hook is not lost on me. I'll use 27 gauge ports for the haptics, but for the vitrectomy and the standard ports, I will stick with 25 gauge. I like the strength of the shafts of these instruments, and I think I get a more efficient vitrectomy with them as well. The superior 27 gauge port is pretty easy to place. Again, this is a right eye and I'm coming temporally. There's nothing really in my way. I'll bevel this a bit more than 45 degrees and just go straight in. The inferior trocar is much more difficult coming over the patient's nose. I had a hard time getting the angle exactly how I wanted it. I end up tweaking the eye over, and it ends up being good enough. As with any dislocated posterior chamber intraocular lens case, I'll start by doing a complete vitrectomy and freeing up the dislocated IOL from all its vitreous adhesions. If you do this effectively, the lens will fall to the posterior pole. With a lens that's subluxed like this one, you want to coax it down away from its adhesions anteriorly. You want to do this gently and with as much cutting function as possible, as opposed to ripping the lens. The last thing you want to do is cause the ciliary body dialysis or any bleeding of the ciliary body at this point that might complicate the case. That said, at this stage I did notice some anterior bleeding from the ciliary body in the area of my superior 27 gauge trocar incision. I suspect that I caused this iatrogenically when making the port. It was not really a problem, however. You can see the lens at the posterior pole spinning around a little bit with the fluidics of the eye while I do my shave. I think this probably makes all of us a little bit nervous, and the theoretical risk of causing some sort of trauma to the neurosensory retina inferiorly is there. That said, I've never seen any evidence of traumatic damage to the retina based on an IOL floating around. And I have a couple of patients with dislocated IOLs that don't want surgery and have had lenses that are dislocated and floating in their eye for many years without causing any problems. I feel pretty strongly that putting perfluoron in the bottom of the eye to somehow shield the macula from the movements of this lens or trauma when grasping the lens initially is by far more trouble than it's worth. You do want to get a good shave on all these cases. You know you're going to be passing instruments and haptics in and around the area of the vitreous base, and there is real risk of causing a tear for any of these procedures. With that in mind, I will routinely do 360 peripheral prophylactic laser for my lens cases. I think it's easy to do, and if you're going to prevent a retinal detachment down the road, especially in a case that has a dislocated IOL, you're doing a tremendous service to the patient and to yourself. For the first time in one of these cases, I experimented by using the green side of the Re-sight lens system for higher magnification for purposes of grasping the haptic off the posterior pole of the eye without traumatizing the retina. I apologize, it's a little bit out of focus on this video. Obviously, I was in good focus at the scope. I initially wanted to grab the trocar at the bottom of the screen, which was closer to the superior port incision, but ergonomically this was a bit challenging, and I opted to go across the eye and grab the other haptic. As long as the lens isn't flipped, it doesn't matter which haptic you initially grab. You want to go for as distal as you can and get a good secure bite and grasp on the end of the haptic. You pull the trocar over the shaft of the end grasping forceps and don't let go. The forceps will do its job and not let go of this haptic. We create the flange using the low-tep cautery, and after this is done, that haptic shouldn't retract through the 27 gauge sclerotomy. Grabbing the second haptic always is a little trickier than grabbing the first. Again, not to belabor the point, but the patient's nose made this maneuver exceptionally difficult in this particular case. I purposely didn't edit out my first failed attempt at trying to grab this haptic. I was hitting the Re-sight with the shaft of the instrument in my left hand, and I just couldn't quite grasp where I wanted to. You can see me using the light pipe here to try to tee up that haptic and push it down into the sphere of influence of my instrument. I ended up bending the 27 gauge forceps right after it came out of the handpiece, which you can see here for a moment, and this made all the difference. Again, in trying to perform this maneuver, I'm displacing the Re-sight a little bit, but it's in place enough where I can see it. After one more failed attempt, I do grab that haptic, and we're able to externalize it successfully. As with the superior trocar, we remove the port and then externalize the haptic, grasp it with the .12 forceps, and create the flange using the low-tech cautery. You can see the lens come up into the proper positioning as we externalize the haptic. I next will take a couple of minutes to adjust the conjunctiva and make sure that the flanges are securely buried underneath the conjunctiva and not exposed to the air. The lens looks good and is well centered, and we're essentially done. I'll pull the 25 gauge ports and do standard subtenons, antibiotic and steroid injections here per routine.